report. And I want to especially, we're honored to welcome one of our special presentations from our founding partner, Exelixis. From the very beginning, KidneyCAN, depended on not only private funding, but also the industry support in holding this meeting. So we truly appreciate all that Exelixis has done for us. And we, even more than that, value the ongoing efforts that Exelixis is taking to develop that next maybe breakthrough drug. So thank you for all that you all are doing. But please welcome to the podium for a few minutes the Vice President of the GU portfolio at Exelixis, Jose Perez Torrealba. Jose Perez. Come right over here.
I thought you were going to talk more.
Yeah. Quick announcements.
Okay, thank you. Well, good morning to all of you. I'm Jose Perez, and I think that I know most of you, and probably a lot of you know me for many years working in the kidney cancer. I am happy, and I need to thank the organizers for letting Exelixis to be part of the agenda of the meeting. And in the personal side, I'm probably even happier being part of the RCC community for many years and having seen grown all the opportunity to treat kidney cancer patients and being part of the contribution to that. Today I'm going to try to talk about the journey that led Exelixis to a non-clear RCC trial. That, as was discussed yesterday, I think that for me was perfect yesterday's early morning session that went into all the deep details on non-clear RCC. As we all are aware, this is a diverse and unrepresented group of patients with kidney cancer in the majority of the trials. Before we dive in, please note that this presentation includes investigational data and compounds that have not yet been approved by the FDA. The intent is solely for scientific discussion and should not be seen as a clinical guidance or endorsement of the off-label use of any of our drugs. Exelixis was founded in 1994, and after that has grown to be an ambitious oncology company and trying to innovate next generation medicines that will be hopefully for the front care of cancer care. Initially, the company was dedicated to model system genetics. And after that, we were established as a broad drug discovery and development company that has served the foundation of continuous efforts to bring new cancer therapies to patients in need. We have more than 100 clinical trials that are either done or ongoing with our pipeline drug, original drug, cabozantinib, and now with a more broad pipeline of new drugs for the future. The mission of Exelixis is to help patients recover stronger and live longer. This slide shows the approved indication of cabozantinib, and we see from top to bottom, RCC, initially as a single agent in second-line and first-line patients, more recently in combination with nivolumab for first-line patients. Also is indicated in patients with hepatocellular carcinoma, differentiated thyroid cancer, and more recently got approval for neuroendocrine tumors. So the initial trials with cabozantinib were focused on the clear cell population. And the idea of these next 10 minutes is to show you how we are now including non-clear RCC in our clinical trial programs. Cabozantinib inhibit multiple tyrosine kinase receptors, such as VEGF, MET, and AXL, and others. These targets are critical for tumor growth, angiogenesis, and immune evasion mechanisms, and those are particularly relevant for patients with non-clear RCC. This is the map of the FDA approvals for cabo in kidney cancer. So the journey started with the METEOR trial in second-line RCC. After that, cabozantinib in first-line RCC as a single agent, and more recently, the CheckMate 9ER trial led to the approval of cabo in combination with nivolumab in first-line RCC. RCC is not a single disease, and I think that all in this room are aware of that. And clear cell RCC accounts for about 70% of the cases. Non-clear cell includes several subtypes like papillary, chromophobe, collecting duct, renal medullary, and translocation non-clear RCC. Each of these subtypes has an unique molecular characteristics, what makes treatment decisions and the design of clinical trials a little bit more complex. This table shows multiple clinical trials in non-clear RCC, and I'm going to highlight the two on the top of the slide that are cabozantinib clinical trials. We see from the cabo-nivo trial response rate in the order of 47.5% and a median progression-free survival of 13 months, with common adverse events that we are all familiar with, like fatigue, PPE, diarrhea, and hypertension. PubMed-2 was a randomized trial with cabozantinib that showed superiority in the progression-free survival versus sunitinib. As I said, the list of all the trials is in the slide, and this is not an extensive list, but we know that most of these trials are single-arm phase 1 or single-arm phase 2 trials, and a few of them randomized phase 2 trials. So definitely, and I think that was also part of the discussion you guys had yesterday, that we're missing a phase 3 trial that could be reported evaluating TKIs or immunotherapy in patients with non-clear RCC. Zanzalintinib is or XL-NI2 is our next generation TKI. We designed the drug keeping the targets of cabozantinib, but trying to improve the pharmacokinetics. It inhibits MET, AXL, MER, and VEGFR, key pathways for tumor progression and immune modulation. The inhibition profile of zanzalintinib is keeping all the same features that are known for cabozantinib. And that targets all those kinases that are important both for clear cell as well as for non-clear RCC. The pharmacokinetics from the phase 1 trials shows that the half-life of zanzalintinib is between 20 and 28 hours, which is significantly shorter than the 99 hours of cabozantinib. There are additional preclinical experiments that are showing that the distribution in healthy tissues as well as in tumor tissues is different between zanzalintinib and cabozantinib. In these animal models using colorectal cancer cells shows that cabozantinib has a broader distribution, including higher concentrations in healthy tissues. Zanzalintinib, on the other side, seems to concentrate more on the tumor cells and less on the healthy tissues. That may be an explanation for difference that we will see further in the efficacy and the safety of zanzalintinib in comparison with cabozantinib. There is a strong rationale, and I think that after several IO-TKI combination trials, I don't think that we need to go deeper into the rationale of why combining an immunotherapy with a TKI. And it seems that zanzalintinib alone and in combination with immunotherapy has shown to promote an immune-permissive tumor microenvironment in vivo. The clinical program of Zanzalintinib has two phase 1/2 trials that are STELLAR-001 and STELLAR-002. STELLAR-001 has explored Zanza as a single agent and combination with Atezo and avelumab. There are, after the escalation phase of the trial, there are multiple cohorts and expansion phase that include patients with clear cell RCC as well as non-clear cell RCC. 2 years ago, Dr. Paul presented at IKCS meeting the first expansion cohort in patients with clear cell. And it shows that the objective response rate in those patients was 38%, and more relevant is that patients who progress receiving cabozantinib, some of them immediately before of getting Zanzalintinib, achieve some level of benefit, clinical benefit, when treated with Zanzalintinib. The STELLAR-002 trial is a trial that includes several solid tumors and explores combination of Zanza with Nivo and Zanza Nivo-Rela. Similar to the STELLAR-001, there are expansion cohorts both for clear cell first line, clear cell second and third line, and non-clear RCC as first line. The primary endpoint of these phase 1 trials is objective response rate, progression-free survival, safety, and overall survival. The outcome of these initial phase 1/2 trials has been used to design further larger trials like phase 3 trials. Recently, at the American Society of Clinical Oncology meeting, results from the STELLAR-002 group of patients, especially in the initial phase of the trial, were presented. And we have the forest plot in the slide. Some of these patients are patients with non-clear RCC, and we see in the cohort that receive patients Zanza with Nivo-Rela, we have 2 patients with non-clear RCC. And in the cohort of patients that receive Zanza 100 milligrams, also with Nivo-Rela, there are 5 patients with non-clear cell RCC. And we see there are different levels of responses to the combination. As part of the expansion cohorts in STELLAR-002, there is one that will include patients with first-line non-clear RCC. The inclusion criteria are patients with the papillary, unclassified, and translocation non-clear RCC, and those patients were randomized to receive either Zanzalintinib or the combination of Zanza and Nivolumab. The data will help us to understand the relevance of using Zanza either as a single agent or the combination with Nivolumab. That led us to STELLAR-304, which is our phase 3 trial randomized between Zanza, Nivolumab, and Sunitinib. The randomization is 2-to-1, which means that 2 out of 3 patients will receive the experimental arm, and 1 patient out of 3 will receive Sunitinib. The inclusion criteria are papillary, unclassified, translocation-associated subtypes, and those patients were treatment naive for metastatic disease. The recruitment status was updated on clinicaltrials.gov Monday this week to show that the trial is active, not recruiting, and the final number of patients that were included in the trial was 317. STELLAR-304 is a real global trial, and we have 172 sites open in 25 countries, from North America, South America, European countries, and patients in Asia Pacific. And I want to finish with a quote from a famous baseball player, which is Yogi Berra. He said at one point, "I knew the record would stand until it was broken." So I want to use this as an idea of what we in Exelixis, we provided through cabozantinib, a drug that has helped a lot of patients with kidney cancer. And hopefully the future will allow us to break what we did with Cabo with Zanzalintinib. Thank you very much.